Health Survivorship Series. I'm Dr. Michael Lutz, and I'm President and CEO of the Michigan Men's Health Foundation. We've been around since 2008, performing outreach activities and services throughout the state of Michigan, and we're very proud of the activities that we've accomplished, particularly this last year in 2025. It's been a great year. We finished up with our men's health event at Ford Field, where we screened over 1,000 men, and we offered some very nuanced procedures this year that we've never offered in the past, including some specialized blood tests for prostate cancer screening, including PROSTEST, as well as a cardiac screening test called lipoprotein A. And the results have been very amazing, and the patients have gotten some great follow-up care as a result of these tests. This event is actually happening because we have great sponsorship, Blue Earth Diagnostics, Corewell Health, Lantheus, and Neo King Physical Therapy. And so we're very excited to put this event on. And tonight we have two very special guests to talk about this exceptional and very important topic called Navigating Tremors, Parkinson's, and Age-Related Movement Changes. So our first guest is Dr. Ellen Eyre, Chairman of the Department of Neurosurgery at Henry Ford Health, and also Chairman of Neurosurgery and Clinical Associate Professor at Michigan State University. She refers to herself as a functional neurosurgeon, and I'm going to let her explain that in greater detail since I don't want to mess it up. Her areas of interest are movement disorders, deep brain stimulation, and trigeminal neuralgia. We also have Charlie Swingle, also known as Dr. Charlie Swingle, because he's a doctor of physical therapy. He's a physical therapist. He's also one of the clinical managers at the Recovery Project, which began in 2003, and I will also have him explain a little bit about the Recovery Project. The goal of this organization is to regain mobility and improve one's quality of life. But before we begin, I think we should learn a little bit more about our guest. So I'd like to have Dr. Eyre talk a little bit about her training and her area of interest.
Sure. Thank you so much. And thank you so much for having me. So I did my medical training and I actually did an integrated PhD with my medical degree at University of Cincinnati. And following that, entered neurosurgery residency at University of Cincinnati as well. Following that, I went to San Francisco, to UC San Francisco and the VA Medical Center there for specialized training in epilepsy, movement disorders, and in pain. So that is what mostly encompasses functional neurosurgery. I like to think of it as we are the group of surgeons who are trying to help restore neurologic function as best as possible. So that encompasses reducing seizures, improving movement in tremors, Parkinson's disease, dystonia. There are neuromodulation treatments for pain as well. So following that, I was originally in practice in Cincinnati for a few years. I came back from San Francisco and had the tremendous opportunity to come to Henry Ford in 2014, and I've been there ever since. It's been just a wonderful experience, and over these last few years, I became chair of the department and fortunate enough to work with a tremendous group of faculty and residents, and now to be able to work with Michigan State colleagues as well.
That sounds great. Charlie, do you want to talk a little bit about where you trained and your practice at the Recovery Project?
Yeah, absolutely. And thank you for having me as well. So initially, for my undergraduate degree, actually, I studied athletic training, so more of an orthopedic background at the Michigan State. And then going into physical therapy school, I did that at the University of Miami down in Florida. Initially, actually, I worked in athletics, so orthopedic sports injuries, up until 2019, closer to 2020. And then moved from Miami back to Michigan and started working at the Recovery Project. At the Recovery Project over the last 5 going into 6 years here, it's outpatient neuro specialty. So we have PT, OT, and speech. We see anything neuro-related, whether it's central nervous system injury, peripheral nerve injury. So our big 5 that we really see the most is going to be spinal cord injury, traumatic brain injury, multiple sclerosis, Parkinson's disease, and stroke, and along with some other diagnoses, ALS, muscular dystrophy. those types of things. And that encompasses for majority of our therapists a good 80-85% of our day. So when I describe the recovery project, it's definitely outpatient neuro specialty.
Thank you so much. I'm so glad to have both of you here because I think this will be a great discussion. So why don't we begin? Aging will affect one's ability to move and cause a decline in muscle mass, strength, and flexibility. And it will also lead to slower reaction times, reduced coordination, and higher risk of falls. And that's kind of the area that I think we need to address tonight is how do we deal with that? How do we help prevent that for people? How do we I recognize it and deal with it? So Dr. Ayer, my first question to you is how do you approach patients when you see them for your initial evaluation, particularly with respect to normal aging changes in one's muscle mass, balance, and mobility?
Absolutely. For me, when I'm working with an individual, unfortunately, I am tending to see them once they've developed some more advanced issues. That can be because of age-related changes that can be from the spine, can be from the brain. Some individuals develop tremors and balance problems. And what we're trying to assess is where in the nervous system is this coming from. Some of it is a natural aging process. And so we want to encourage individuals to work with, physical therapists such as Charlie to maintain and keep exercise to maintain muscle mass and agility as well. So balance and agility is really important. And also to try and some part of the assessment sometimes is taking a look at, are there other factors going on that may be adding to the challenges that they're having? Are they having problems with blood pressure management that can make somebody feel unbalanced or lightheaded? Are there sugar problems? So we really want to understand the full spectrum of what things could be contributing to these issues, and then try to work on the medical issues as well as encourage continued activity.
So Charlie, you get many referrals from people like Dr. Ayer for evaluation. So just out of curiosity, what would be your evaluative process when patients are referred to you for neurological orthopedic conditions?
Yeah. So for us, once we get that prescription for physical therapy, typically coming through the door, of course, I would take a look at what the potential impairment or diagnosis is that they're coming to see us for. And then what we really do is we take a history determining what activities someone may be struggling with, what impairments and activities of daily living. Is it walking? Is it getting up from a chair? Is it navigating stairs? And then from that standpoint, after we take the history, we're going to do our evaluation or examination. So what we like to do is we use objective measures to determine where their potential functional impairments are. And these objective measures are basically looking at endurance, lower extremity strength, balance, your gait speed or your walking speed, and your flexibility, and as well as posture. And what we do is we compare these outcomes to age-related norms. So we can compare to a 70-year-old man over one of the tests that we use for endurance is called a 6-minute walk test, for example. And we see how far you can walk in 6 minutes. And we compare that to, for a 70-year-old man, that puts you in the 10th percentile, 90th percentile. And then from there, we can gather, okay, this is something that you noted in your history has been a challenge for you. And also our objective data is supporting that as well. It's something that we're going to want to work on and develop a program for you to also work on it at home in therapy. And so that's kind of how we evaluate where the issues are that we need to work on.
One of the things that I know that Dr. Ayer just mentioned was about tremors. And one of the things that we do notice is a lot of people as they get older have tremors. So my curiosity to you is that, we know that all tremors are not Parkinson's. So I'd like you to elaborate on that and how common are tremors and how do you deal with that?
So tremors are very common. Actually, essential tremor, which is just one of the kinds of tremor that we talk about, is the most common movement disorder. and is about 4% of the population. Essential tremor tends to run in families. It's not 100%, but it tends to run in families. And it tends to be when somebody is trying to do an activity. So if they're sitting at rest, have their hands resting on their lap, they're not going to necessarily notice anything. But when they go to try and say, pick up a cup or move something, try to point at something, that the tremor gets more intense and tends to get even more intense the closer somebody is getting to the target of what they're trying to accomplish. So it can be incredibly disabling. And sometimes people will notice that if they have like a sip of alcohol, their tremor goes down a little bit. That's one of the ways in which we can kind of distinguish between some of these. I'm not encouraging that as a way to treat it, but it is one of the signifying differences. In addition, there's Parkinson's tremor, as you mentioned, and actually not all individuals with Parkinson's have a tremor. That tremor tends to be one where they experience it while they're at rest. So we call that most classically a pill rolling tremor. So the hand, if you can see, will sort of, it's like somebody is rolling a pill in between their fingers, and that'll naturally happen as somebody is sitting at rest. And it may go away as they go to make a motion, but if they then place their hand in another position and it rests there, then the tremor will come back. For individuals with Parkinson's, they typically will have other signs like stiffness and slowness. Younger individuals with Parkinson's can have a pretty significant tremor that outweighs the other signs of Parkinson's. And so it can be a real struggle. But we also have some, weird, or I won't say weird, but uncommon, less typical types of tremor. If you're nervous, everybody has a tremor to some degree. You get real nervous, so we want to make sure we're ruling that out. Checking whether or not somebody has signs of other issues with their brain wiring that may cause twisting of muscles. That's called a dystonia or dystonic tremor. So there are a number of different types, and that analysis, that assessment, really, as Charlie was talking about, working with somebody and evaluating them is so important to discern what type of tremor, because that then helps us guide what the treatment options are.
So stress and anxiety play a mild, moderate, significant role?
So I would say a moderate. So some people can certainly have a tremor just that comes out because they're nervous, right? That's a physiological tremor that just comes out. But if you have a tremor from something like essential tremor, something like Parkinson's disease or dystonia, anything that additionally stresses your nervous system will tend to make those things worse. So bad night of sleep, not getting sleep, being ill, lots of things that are otherwise stressful to the nervous system can also bring those things out.
Thanks. Charlie, just out of curiosity, are there some physical therapy treatments that you can use for tremors?
Yeah, absolutely. So again, the finding the root cause of it is extremely important to us, and that information for us as physical therapists and the occupational therapists that I work with as well. That's very important for us determining what our interventions would be. For a diagnosis like Parkinson's disease, in physical therapy, we'll use things like external cueing. We'll use things like using a body weight supported treadmill training, which is where you're put into a harness over a treadmill and walking at increased speeds to get a increased heart rate. So moderate to high intensity exercise to work on getting oxygenation to the brain. The external cue for, not so much of a tremor, but with Parkinson's may see some freezing of gait is a very common symptom that we may see. That is something that we can use for a cue to have them step to this laser. Imagine stepping over an obstacle. For a tremor, let's say in the right hand, and somebody is right-handed and they have trouble with feeding, grooming, dressing, bathing, those types of things. Our OTs can use things like a larger handled utensil or pen for writing, using weighted pieces of equipment like a toothbrush or a larger handled toothbrush. All these things can help a lot with managing tremors, and we call them like an activity modification, so that they can still maintain that level of independence and perform their activities of daily living independently or with as little caregiver assistance or family assistance as needed. And one other item I know we were talking about stress a little bit, so I did want to touch on that a little bit too. So in the event that, stress is either increasing that severity of the tremor or prevalence of the tremor, or if it's, causing a potential abnormal movement, something that falls under a functional and neurological disease, for example. One thing that we do in therapy as well, and it's a big education piece, is educating on how to kind of calm down your nervous system. So when we think of the autonomic nervous system, we have our fight or flight response and our rest and digest response. So we work a lot on things like body scanning, things like meditation, to learn how to kind of get that parasympathetic or rest and digest portion of the nervous system activated, which can be very, very effective in helping to manage either an increased incidence or, an increased severity of that tremor, or if it's a scenario, I want to go down too much into the weeds, but for a functional movement disorder, neurological disorder, helping to completely treat that.
I've seen an abundance of chair exercises as of recent. Maybe it's because of my age and all the algorithms. But just out of curiosity, how do they fit into the program? And can or should anyone do chair exercises?
Yeah, I mean, so in terms of what you're, going back to when we first see somebody in that evaluation, we look at their mobility status, right? So what are they using as an assistive device? Are they using a walker with a seat on there, what we call a rollator, for community mobility? Are they utilizing a wheelchair, a scooter for that mobility? And in that, as we're working on getting to standing exercises or standing activities, it's so important to be able to progress your strength, your endurance, your flexibility, that you're exercising at what is tolerable and safe. If somebody's in clinic with me, we have all this nice equipment, harnesses, belts, parallel bars, these things to make sure that in a more challenging exercise, it would be safe. But I want to make sure that somebody can do their exercises at home too, because spending 2 hours a week with me, 3 hours a week with me, that's not gonna meet the activity needs that somebody can benefit from. For something like Parkinson's, what research supports is 150 minutes of moderate to high level exercise intensity. What moderate level means from the research, when they're calling that's 60 to 65% of your heart rate max. For high intensity, that's 70 to 85% of your heart rate max. So in that, we want to make sure that we can still do those types of interventions outside of just what would be in physical therapy, because again, that's 120 minutes a week. Maybe it's only an hour a week, 100 or 60 minutes. So there is exercises with your arms, legs, your trunk, your core that you can perform from the chair that are extremely beneficial and can help progress your level of function. You can strengthen your calves, your thighs, your hamstrings, your backside, which is very important in getting up from a chair or from a toilet or any other seat. So all these things are so important, and exercise, whether it's from the chair or in standing, has massive benefits.
Thank you so much. And there's no question, physical therapists have all the toys. You definitely have all of them.
Yeah.
I've been in physical therapy, and it's incredible how many toys you have. Dr. Ayer, you previously mentioned that individuals, when they come down with Parkinson's at an earlier age, they have more tremors, if I'm not mistaken. I'd like you to talk about how Parkinson's isn't really one disease, that it can have multiple presentations. And I'd also like you to talk a little bit about one of our most famous Parkinson's patients that we've seen, he's Michael J. Fox, because he was fairly young when he was diagnosed. and how that may play out differently than an individual who gets it at more of a standard age, maybe later on in their lives.
Yeah, absolutely. I would ask everybody to take this as generalities because each person is unique, and there are individuals who get a more of a slower, rigid type of Parkinson's earlier. Some, I would say, it tends to be on the younger side that individuals start out with a tremor dominant Parkinson's, or at least of all the average age amongst patients with Parkinson's, the younger ones when at diagnosis tend to more often present with tremor. Well, I guess I'll phrase it that way. But everybody is unique, and it is a constellation of symptoms. And often it takes more than one evaluation with a specialist, with a neurologist, with a movement disorder specialist to really understand what the movement disorder is, because it changes over time, and how it progresses tells us something about what is going on physiologically. So when somebody shows up with a tremor, I can't necessarily say just on one single examination, it's definitely an essential tremor or it's definitely a Parkinson's tremor. And there is some crossover between those two in some individuals who honestly have both forms. So we really have to look at each individual uniquely. Parkinson's, as I said, is a constellation of symptoms. And so what we call the cardinal symptoms, the key big ones that point to the diagnosis: bradykinesia, so slowness of movement, rigidity. And so people will actually have, as they try to move their joints around, it'll feel like the joint is getting stuck. Instead of a smooth movement, it'll feel like it's getting stuck along the way. Balance is just a shuffling of gait, short, narrow stride, not picking up the feet, not swinging your arm as well when you're walking, and then tremor. So all of those are part of Parkinson's. Those are the motor aspects. There's so much that individuals with Parkinson's disease can experience that can be just as debilitating as the motor symptoms. People can have very vivid, restless dreams that interrupt their sleep. They can have challenges with drooling or constipation, small handwriting. Oftentimes their face will become less animated, and they'll feel certainly some social reticence because they just can't have the same facial expression that they used to. So that's sort of the constellation, and each individual can have some, part, all, and how those evolve over time is quite unique.
It's interesting. You talked about the rigidity and the masked face. I had a very, very close friend of mine who had Parkinson's, and his wife absolutely could never understand it. And she used to always yell at him and say, "You don't smile. Why do you don't smile?" And I used to feel so badly because that was just not him. And he was a very happy and happy-go-lucky kind of fellow. But people have to understand that these are very debilitating diseases, and really can affect every aspect of your life.
And really affect how you, like to that point exactly, how you interact, whether or not you feel comfortable going out in public.
Sure.
I mean, I have a dear friend who also has Parkinson's, and one of the things that brought her to seek a next level of treatment was she felt like she could see when she was in public that people were watching her arms, people were watching her shuffle, and people were watching her tremor.
Yeah. Do you have an initial approach to treatment for individuals once diagnosed with Parkinson's?
Yes, certainly the key is typically starting a medicine, a dopamine replacement medicine. Cinnamon is the typical one. It's a generic drug that's been out and been an oldie but a goodie for a very long time. Whether or not somebody responds to cinnamon actually helps us in the diagnosis and confirming whether those symptoms improve. But I would say we have become even more aware, to what Charlie was talking about before, about the data around exercise is being incredibly intentional. Not that I mean, we're doctors. We always want people to be exercising and getting their cardiovascular health improved and their muscle strength, et cetera, improved. But in Parkinson's disease, the one thing very clearly with an asterisk around it that has been shown not only to improve symptoms, but to reduce the progression of Parkinson's disease is exercise. So that is now a first off the bat recommendation that we're making in addition to working through various medication options.
And I was going to ask Charlie a couple of questions in that regard. It's specifically for like boxing and dancing and other types of things that people, what can they do to help kind of stave off some of the progression of the disease?
Yeah. So boxing is a great one. So there was initially a gentleman who was diagnosed with Parkinson's disease that was started exercising, and boxing was their choice of exercise. And from that, he had fantastic outcomes with, like Dr. Ayer was saying, delayed progression of his disease, managing his symptoms better. And from that, there's been different boxing classes that have come about that are Parkinson specific. And really, the reason that boxing or a Tai Chi or a active yoga type scenario group class are so effective for Parkinson's diseases. And when we talked a little bit about the 150 minutes a week is the recommendation of moderate to high intensity exercise. Obviously, I don't know if anybody listening, but if you ever done a boxing class or anything like that, that's going to get the heart rate up, and that would likely meet the criteria there. But the other thing is, those types of activities are promoting large amplitude movements. And so Dr. Ayer was talking about the symptoms that we typically see with Parkinson's disease, and one of those was rigidity, right? And that slow movement, that bradykinesia. So as you can imagine, with something like throwing a punch, the amount of movement that your joint is going through and how far you're going is kind of the exact opposite of what Parkinson's symptoms are trying to or are doing. So you're fighting against those symptoms. And so these group classes or these types of exercise are so important, in addition to going to physical therapy after an initial diagnosis, right? So like Dr. Ayer said, that exercise component, they're going to go see a physical therapist and they're going to get an home exercise program or an exercise program where they're going to get progressive strengthening, and they're going to get recommendations on endurance or aerobic type exercise, whether that's if somebody is, has good balance and it wouldn't be a fall risk. Something that I would recommend is utilizing something like a treadmill or walking through your neighborhood, not in December in Michigan when we had the weather today, but if somebody may be having some more mobility impairments where the balance is something that we're working on in therapy, cycling would be a great option, where it's something that's stable and safe. And, we're going to work on in therapy, getting your balance back and getting your gait improved. And so in therapy, those couple hours a week, which is typically what it is wonderful. But then doing some type of exercise outside of that is so important too. And there's a lot of group classes. There's boxing classes. There's some are called like power flow classes or LSVT big classes. These types of things are fantastic. It's something, that we have at the Recovery Project too, and that I would always recommend to my clients, because I want them meeting what the research is supporting for that exercise amount. And, we talked a little bit about the non-motor symptoms of Parkinson's too, and depression can be one of those as well. And these group classes, from what I've found with working with many, many individuals with Parkinson's, they're in a class with somebody else with Parkinson's, and they become friends. They talk about how they're managing their symptoms, doing specific things at home, talking about where they're at in that disease progression. And it creates a community too. And that part is so important, as well as the physical part of things.
So Charlie, in addition to some of the exercise components to physical therapy, do you have any other components that you like to make sure that people get as part of their physical therapy for Parkinson's disease?
Yeah, a big part of, we talk a lot about the exercise, but a big part is education. Education on what to kind of what to expect to a certain extent. Again, everybody is different, but to understand that, unfortunately right now we don't have a cure for Parkinson's. And so the things that I like to educate, and I spend a lot of time on this, the things that you can do as the individual to help slow that progression of the disease and to improve and manage your symptoms. There are a lot of things that can be done to do that. Exercise is one of those big parts, but that education piece of working with somebody with Parkinson's is so important. And it's a big part of my interventions, or I guess my plan of care when I'm working with somebody.
That's great. Thank you. And Dr. Ayer, something that we've not talked about as of yet is ALS, or amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. Mm-hmm. There are many famous people who've helped bring attention to this disease. And most recently, Eric Dane is one that has been, I'm watching his story, and it's just so moving to watch this. Also, we've had people like Roberta Flack, Stephen Hawking, and of course, in our area, Maury Schwartz, who's from Mitch Albom's book, Tuesday with Maury. I just want to know what makes this progressive disease so unique, and how is it diagnosed and addressed?
So it is, as you can say, as you just indicated, obviously, watching the progression can be heartbreaking in many ways, because we don't have a cure for it, and we know that it is progressive, and it tends to start low and kind of continue up the body. Probably one of the toughest parts is that the individual is very aware of what's going on, even as the disease progresses. And it can often be a situation of deciding whether or not to make a choice around supporting lung function. So there are lots of new treatments that are I know in study, coming out in progress. But we don't have a cure, as I mentioned. Still, even in that situation, even when somebody has lost their independent function, their independent ability to move, how well someone does is related to maintaining some level of movement, and whether that's passive movement of the arms and legs in somebody who can't move them themselves, because that is important for reducing some of the stiffness, reducing things like bed sores and blood clots and all the other things that come along with the loss of mobility.
Yeah. And Charlie, what is there a role for physical therapy for patients who are suffering from ALS?
Yeah, absolutely. So in terms of, when we have somebody with a ALS diagnosis, in terms of evaluation, depending on where they're at in that disease progression, is really important for, what we're working on. If somebody is utilizing a power wheelchair for their primary mobility, there's a lot of education for caregiver education or family member education on, and Dr. Ayer mentioned this, on flexibility to prevent things like joint contractures, on when it's appropriate to, or when it's necessary to turn position where they may be laying in bed. A lot of the power wheelchairs now, they have excellent cushions that can help disperse some of that pressure. But at the same time, a chair that has tilt and space abilities will be really important, and something that we recommend to also help with some of the respiratory difficulties that may be occurring. When I have somebody that's just recently been diagnosed with ALS and they're coming into the clinic, at that time, typically they're ambulatory. But I do spend a good amount of time educating on the disease process and kind of what to expect and why, or what our plan of care will look like. And I tell them that we're going to be working together, and we're going to each month do we call it a progress note. but we're going to see where their function is. And I talked about those objective measures, for those general objective measures. I use those as well in an ALS diagnosis plan of care to see where are we declining? Is it in the endurance? Is it in the strength? Is it in the balance? And really, it's important for us as physical therapists to continue to communicate with the patient and their family members on things like, okay, this is where we're at in December, but you're starting to have more trouble with ambulation. We're needing to use bracing to help clear the foot. We're needing to use assistive devices to, get around safely. You may be noticing more falls or frequent falls or difficulty getting up from surfaces. And at that point, it's very important to bring in an ATP, who's a wheelchair seating professional, and start that wheelchair process at that time so that we can make sure that we have that wheelchair ready to go and that the home environment is ready for that as well, to allow for that wheelchair to be utilized and for their safety and their function to prevent, falls, again, bed sores, those types of things, any secondary complications or secondary hospitalizations. So there's I would say a major role in what we can do with ALS. And I think the sooner after diagnosis somebody can get to a physical therapist, the better.
Dr. Lutz, I was going to say, if I could, I would really love to put an exclamation point on what Charlie was just talking about in terms of mobility and safety. It is true for ALS. It is true for any balance problems. It is true for Parkinson's, tremor, et cetera, that, understandably people feel a tremendous sense of loss of their normal activities and often are very reticent to add a cane to their routine or a walker to their routine. The flip side of that is losing the safety and potentially losing more mobility, and the injuries when somebody is ambulating without assistive devices that they really could benefit from can often tip somebody over into a far more severe situation, broken arm, broken hip, what have you, that then sets them back even further. So if I had anything that I would really want people to take away is certainly understandable that feels like a significant loss to have to make such a move. But the benefits of that in terms of maintaining independence, maintaining mobility are so critical.
I think you hit the most important topic of the day, is maintaining one's mobility, balance, and stability. And I can tell you that having treated patients for 40 years, the one thing watching men age in my practice is when they lost that and they lost their mobility was the saddest part of watching somebody age. And that actually gets me to my next question, which I would like to pose to both of you. And we'll start with Dr. Ayer. About men will lose about 50% of their muscle mass from age 40 to 80. And the question I have is there a way to prevent or reduce and or help men regain this muscle mass after age 60?
Well, certainly the best way is to try and minimize loss up front. So maintaining weight-bearing exercise, that's really true for everybody, is weight-bearing exercise. Having a diet that ensures you have enough protein. One of the things is, individuals get older, their appetite can change, and so are not necessarily getting the same amount of protein that would be beneficial for maintaining muscle mass.
And Charlie?
Yeah. So again, it's the saying everyone's heard it, use it or lose it kind of idea, right? So in terms of that, the recommendations, we've talked a lot about aerobic exercise and the importance of getting the heart rate up. Resistance training is so important too, especially to slow, delay that loss of muscle mass that occurs after the age of 30, that starts to occur even, at 2% a year is what some of the statistics say. But doing resistance training is so important 2-3 times a week to help slow that. It's going to be so important for things, not only just your overall strength and your metabolic system, even how your blood sugars manage, these types of things, having more lean muscle mass, but it's also important for, Dr. was talking about falls, right? And mobility and the risk of fractures. Resistance training is fantastic. Weight bearing exercises are fantastic for bone density. And in the event that you do have a fall, things do happen in life. If you are strong and you have good bone density, the risk of something like a hip fracture, which can be so detrimental to one's health status, decreases. So we talked a lot about the aerobic exercise, but same thing for progressive resistance exercises, using weights, using resistance bands, doing squats, lunges, whatever that may be, is so important for one's health status as they get older.
And I know Dr. Ayer especially is functional neurosurgery. And so my question is what functional changes do you notice in men as they age? And are these oftentimes related to degenerative changes such as spinal stenosis or other neurologic dysfunction?
You know, I like to say aging is not for the faint of heart, because there are so many things that can be that kind of start adding up on them. Certainly, degenerative changes in the spine is absolutely on that list. That can manifest in a number of different ways. If it's lower in the back, then individuals can have problems with pain in the legs or feeling like they're weak, not able to walk very far, having to stop because their nerves, they get something called claudication, where they can't continue too far because the blood flow and spinal fluid flow to the nerves can't keep up. It's happening in the neck that we certainly worry about, because if it becomes severe, can impact the spinal cord itself and ability to use your arms for fine motor activities. It can impair somebody's walking. So spine disease, and that is just so common. It is really a common complaint and a common issue in aging. For that, we also don't have a ton of great things that certainly would prevent it. And some people are genetically going to be more prone to that degeneration than others. On this area, I would say core strengthening exercises are really the only thing that I can be clear about to say can make an improvement both in symptoms and in slowing down the way in which the spine is settling on itself. But that's obviously just one piece. Individuals tend to lose a little bit of sense, particularly if they have any sort of neuropathy, whether that's from diabetes or other types of peripheral neuropathy. There are limitations in being able to sense where their feet are hitting the ground, can lead to balance problems or missteps. So aging can come and impair those mobility issues in a lot of ways.
Yeah. I didn't get a chance to ask you earlier about some of your neurosurgical treatments that you do for advanced Parkinson's disease, such as deep brain stimulation. How do you know when a patient is a candidate for a deep brain stimulator, and how do they work?
Sure. So a deep brain stimulation is approved for a number of issues. It is approved for tremor. It's approved for Parkinson's disease. It's approved for dystonia. It's actually approved for epilepsy and for obsessive compulsive disorder. No, not what we're talking about today. When we're looking at tremor, it's somebody whose tremor is just not controlled with medications. And frankly, that happens not uncommonly because the medications for tremor kind of have their limits. In Parkinson's, it's when somebody is starting to experience fluctuations, or they take a dose of medicine, and that dose, sometimes it helps their symptoms, sometimes it doesn't, or sometimes it lasts for 5 minutes and sometimes it lasts for 2 hours. And people get into a lot of fluctuations where they cannot predict. And if anybody has ever heard some of the interviews from Michael J. Fox, you mentioned him before, he would talk about showing up at, say, at a ward party or something like that, and that the car would have to drive around extra times depending on when his dose of medicine would kick in, and not being able to have some predictability around that is a real challenge. So that's when we start thinking about these more advanced interventions. Obviously, if someone is really struggling with some of the depression and dementia issues related to Parkinson's, we're less inclined to go that route. But it can make a big difference in maintaining and helping to support maintenance of mobility.
That's great. Thank you very much. And Charlie, I just wanted to touch a little bit more onto what Dr. talked about her functional changes and functional assessment of men as they age. Are there any at-home tests or any at-home testing type of technologies that are available that men can do to see if they're at risk for falls or instability?
So in terms of, it's a great question, because I know it would be really convenient for kind of doing something like an objective balance test. But typically, I always just say this: if you're starting to know, or your loved one, your wife or a family member is starting to notice that you're having some balance and impairments, or noticing that your walking or your gait seems, you're not taking as big of steps, or you're not doing this activity you used to enjoy to do, and your body has a pretty good job, sometimes overprotective, but we'll give you reminders of wanting to protect you. And maybe you would just be like, I don't know, I don't really feel comfortable doing that activity anymore, walking the dog around the block or anything like that. Anything that's indicating kind of a change in your normal activity or where your confidence level is with things like getting around. I always recommend seeing a physical therapist, because we have very structured balance tests. I wouldn't want somebody that potentially has a balance impairment to do it at home on their own, because typically I'm right next to them. And these tests are, again, putting you in positions where we can see what level of ankle or hip strategy or step strategy, or basically like your reaction time and things like that are. And doing that at home with following a video online, I would just rather have it initially done with somebody with you. So I don't have any tricks at home, but the main thing for at home, or for anybody, watching this or kind of thinking, is my balance potentially an issue? Just looking at your day-to-day activity and noticing, have I caught a toe here or there? Have I needed to grab onto furniture or use furniture to get around now, to go from one room to the other, and those types of things? Those can be an indicator of having a balance impairment, and something that a physical therapist can help work on.
Well, I always say knowledge is power. So I would encourage any man who's actually listening in on this and is doing this, following us for just the natural aging process and is curious, is go out and seek some help. Talk to the primary care physician, get a referral for physical therapy, and just get evaluated just to see where they're at. And because falling is not a good thing. And at that point, it's already too late. And so you want to be warding that off. And I know Dr. Era was tried to put the pin on that one, because it's really important to prevent falling, because the healing process from a fall is a lot worse than you can imagine and can sometimes be fatal. And so that's something we don't want anybody to ever succumb to. I want to just really thank our guests tonight. We were very fortunate to have Dr. Ellen Ayer with us from Henry Ford Health, and as well Charlie Swingle from the Recovery Project. Again, these events wouldn't take place without our sponsors: Blue Earth Diagnostics, Corewell Health, Lantheus, and Neil King Physical Therapy. For resources and support regarding Parkinson's disease, I recommend reaching out to the Michigan Parkinsons Foundation and or the Parkinsons Foundation. And in our comments section for tonight, that will be available for you to find them if you need resources. That is what they are there for. They are there to help you in a time of need. And so please feel free to reach out for these resources to help you and your family. The Michigan Men's Health Foundation is very excited to talk about 2026. I am very excited to talk about it, even though I know Andrea Hamilton, our executive director, starts to break out into a cold sweat thinking about all the activities for 2026. But since she's not here right now, I can talk freely about this and know that she's not breaking into a cold sweat. One of the things that we are launching in this year is our mobile men's health unit. We have purchased the vehicle thanks to a very generous donor. It is being built up at this point, And we hope to be on the road in the first quarter of 2026 to underserved communities, going to firehouses and churches and other venues to actually help screen men of the needed health care that they should get, and to bring attention to unmet resources and needs. In June, we'll be holding our special events, our Blue Monday event on June 15th, as well as Cogs and Kegs, a cycling event at Lincoln Yard on June 15th. Our Run for the Ribbon, which is our prostate cancer survivorship event for patients and their families, will be held at the Detroit Zoo on June 21st. And I'm also very excited to say that this year we'll be moving our men's health event from Ford Field to the Wayne State University Fieldhouse. And we have a date already in hand, September 26th. Yes, you've heard it first here, September 26th at the Wayne State University Fieldhouse. In closing, I'd like to say, if you have topics that you'd like to learn more about, feel free to go to the info at the mi-menshealthfoundation.org. And I just want to say thank you very much for joining us. Thank you to our guests, and may you live and be well and keep balanced.